But one thing that we know very clearly from both the opioid crisis and that's being demonstrated now with COVID, when people are presented with overwhelming statistics on an ongoing basis, the numbers stop having an impact. So I'd like to take a second and speak a little bit about the people that this crisis is actually impacting. So I'd like to introduce you to Dan. Dan's 28 years old. He's a seasonal worker. He's single. He's renting a bachelor apartment. He's had a number of injuries over the years, and he's been on and off prescription painkillers. He began to use Oxy between prescriptions when the pain started becoming chronic and when he started experiencing withdrawal between medications after one prescription ended and before he started the next. When he couldn't get Oxy anymore, he moved on to other opioids. He doesn't use large amounts, just enough to keep the back pain in check so he can keep working. After Dan didn't show up for work for a few days in a row, though, his boss began to get a bit worried, got in touch with his landlord, and Dan was found dead of an opioid overdose in his bachelor apartment. When we think of people who are dying of drug overdoses, we often think about people who are marginalized, people who are vulnerable. There's the stereotypical photo that we see in the newspaper of the person with a needle in their arm. If I never see another of those photos, it will be too soon, because those aren't the only people who use drugs in society. They're not even the majority. We do know that there are some consistent correlates of death due to overdose during the opioid crisis. It's usually neighborhoods who have high levels of material deprivation, usually urban centers. Most of the people are single, most of them are male. Most of them are in a private home. We're not talking about people on the streets here. These are people who are using in their own residence. The reason they're dying is because they are using alone and there's nobody there to intervene when there's an overdose. Okay, so good. The other thing that we're seeing, and this is more of an emerging crisis, is an increase in methamphetamine use in Canada. Now, the table that you see in front of you speaks to results of a population level survey, which doesn't really get at the depth of the issue, because methamphetamine use isn't usually among highest among the populations that are accessed by population level surveys. So that's people who, for example, are housing or street involved, people who are young but who are not in school. So I'm going to tell you a little bit more about who we're seeing impacted by the meth crisis. So introduce you to Sue. She's in her early 30s, lives with a boyfriend, but sometimes accesses emergency shelter systems because it's an abusive relationship. She's had struggles with depression. She's tried community-based treatment for substance use, but hasn't really stuck. One day she presents to your emergency room in a state of complete psychosis. She started using meth occasionally to get through the day. She's been doing some sex work to try to make ends meet, to keep alert, to just feel better, basically, about herself. And at only $5 a point, getting meth is a lot cheaper and easier than trying to keep the coke going. Oops, sorry. But recently, when she's tried to cut back, she can't handle the lows in between. So she's been using more consistently, and now she's been using for about a week on end, hasn't been sleeping, hasn't been eating. She's causing a huge disturbance in the emergency room. Finally, the police are called in. She kicks one of the officers. She's arrested, and unfortunately, she's taken to detention. So I've told you a little bit about who this is impacting. And now to come back to the topic of the event. We'll start in Vienna at the United Nations. So this is the home of the United Nations Commission on Narcotic Drugs, which has been working toward the goal of a drug-free world since 1946. The Commission is the governing body of the UNODC, the United Nations Office on Drugs and Crime, responsible for supervising application of the treaties. The Commission is composed of 53 member states. The Commission governs the 3 international treaties. The Single Convention is the foundation of those treaties, requiring that possession of scheduled substances, as well as trafficking, importation, distribution, production, etc., be a punishable offense. Historically, the work of the Commission has focused on achieving the goal of a drug-free world through prohibition and enforcement. This approach has provided the foundation for a litany of human rights transgressions, stigmatization, and the growth rather than the reduction of the illegal market. Examples of the impacts of the prohibitive approach include crop eradication that has resulted in environmental damage and displacement of indigenous peoples and farmers, especially in South America. Extrajudicial killings in the name of wars on drugs. In the Philippines, for example, there are estimates of over 20,000 people dead under the current leader, Duterte. The emergence of narco-states, where members of illegal cartels control political decision-making and thousands are killed in feuds between drug gangs. I think probably most have heard of a lot of the violence that's happening in Mexico right now, for example. It's important to note, though, that the treaty was to controlled medicines for the relief of pain and suffering, placing them in a very difficult position of striking a balance between control and access. Unfortunately, that focus on drug control historically has also eclipsed the need to ensure access to our essential medicines. The International Narcotics Control Board, who is responsible for monitoring the implementation of the treaties, stated in its 2019 report that the goal of ensuring the availability of and access to narcotic drugs and psychotropic substances for medical and scientific purposes is still far from being universally met. A study by The Lancet found that whereas Canada and the US have sufficient opioid analgesics to cover 3,000% of their need, 3,000%, over half of the countries studied had sufficient supply to cover less than 20% of the need, and that's mostly located in lower income countries. The political nature of the debate is evident, with a strong movement in 2016, for example, by China and by like-minded nations to move ketamine to Schedule 4 of the 1971 Convention. The intention behind this was to address a trend in ketamine misuse in China. However, the impact of that scheduling would effectively have been the removal of access to this essential medicine that is the most and sometimes the only available anesthetic in low-income African countries. Fortunately, the rescheduling did not take place. However, we are seeing developments. Over time, we're seeing a shift at the global level with increased recognition that the goal of a drug-free world may be neither realistic nor achievable. UN bodies have explicitly recognized that the treaties allow considerable latitude and alternatives to conviction or punishment for individuals experiencing problematic substance use. There have been reports published by the UN promoting alternatives to incarceration and from the criminal justice system, including some specifically recommending decarceration in light of the current COVID pandemic in order to reduce community spread. But the fundamental shift that many have hoped for has not yet taken place, and the divide between punitive and reform-oriented states may in fact be growing. So if you're wondering where Canada sits in this debate, we've actually been driving a lot of the dialogue, particularly with regard to harm reduction, respect for human rights, and stigma. So we are seeing through the dialogue that Canada's been a part of and other states internationally, a lot of EU nations, for example, pushing for greater recognition of drugs as a health issue. We're seeing an increased role of civil society, which 10, 15 years ago was practically unheard of at the Commission on Narcotic Drugs, which, civil society, as you're probably aware, really has much of a stronger voice when it comes to issues around human rights, access to safe medicines, et cetera. We're also seeing greater intersectoral and interagency coordination and collaboration. A lot of this has taken place between the World Health Organization and the United Nations Office on Drugs and Crime, and also under the Social Development Goals, which has presented an opportunity for more of a whole of UN approach to a lot of health and social issues. So I'll move on to drug regulation in Canada. So if we sort of think of the pyramid drilling down, we started at the broad international level. If we move to Canada, oops, sorry, wrong way. Illicit drugs are governed by the Controlled Drugs and Substances Act, which falls under the responsibility of Health Canada and establishes prohibitions and penalties for scheduled substances with regulations and exemptions to allow for industrial, scientific, and medical use. Traditionally, the approach has very much been a punitive and prohibitionist approach, but we are seeing many options and exemptions, particularly over the last 5-10 years with regard to harm reduction approaches and alternatives to criminal justice. Things like drug treatment courts, supervised consumption sites, overdose prevention sites, the Good Samaritan Law, which enables people to call 911 if they witness an overdose without fear of prosecution themselves. We're seeing increased access to lower threshold treatments, which I'll get into a little bit more. Of course, we've seen the introduction of medical cannabis and now the legalization of cannabis for non-recreational purposes. So that provides the umbrella, but as we know with all health considerations, implementation can vary considerably at the provincial, territorial, and municipal levels. So the federal government sets the overall stage, and then the provinces, territories, and municipalities are responsible for various levels of implementation. What that means is if Sue, for example, is in Winnipeg and reports to the emergency room with the state of psychosis that I described earlier, she would actually have access to a safe space where she would be placed in a quiet setting with supportive staff who would help her calm down, and once she's calmed down, help her get access to some supports, some food, a safe place to sleep, etc. However, most places in Canada would not be able to offer that type of support, particularly outside of urban centres and in more rural communities. We've also seen issues around access to opioids. For example, if we think of somebody like Dan, who's moving frequently to access different job sites, maybe he's tried to stick with a methadone prescription, but it's just too big of a pain to try to transfer that prescription every time he moves to a new job site. And in some of the sites, there's not a prescriber available. So moving on to impacts, and again, I do feel like I'm really rushing. I apologize, but I can expand on any of this.
Hi, Ms Jesseman. Yes, you have 15 minutes. If you have time, you have 50 minutes, so you can take your time to
okay.
expand on your presentation.
I wasn't sure if we were still on the original cutoff time, so
no, it's okay. You have like until 3:30, so that's fine. Okay. Yeah.
All right, I'll slow it down. Thank you. All right, so in terms of the impact that this has on Canadian society, my organization, the CCSA, has done an analysis of the costs and harms associated with substance use in Canada. The numbers that you see right now are for 2014. We are currently updating to 2017 with a revised methodology. And unfortunately, we're not quite there with the numbers yet, but what I can tell you, what we're seeing right now in our current estimates for 2017 is approximately 46 billion in overall cost to society, with a considerable increase in costs associated with opioid use, now that we're capturing some of the stronger impacts of the opioid crisis in that time period. As you can see, tobacco and alcohol, the two legal products, continue to drive most of the costs associated with substance use in Canada. But also, as you can see by the blue sections, particularly with regard to cannabis and cocaine, criminal justice associated costs continue also to play a driving role, particularly when it comes to the illegal market. Those costs include police enforcement, courts, etc. And they don't capture some of the impacts that criminalization has on the individual in terms of their ability to access employment, housing, education, etc. So in terms of criminal justice drivers, when I speak about the increase in methamphetamine concerns, again, going back to the population level, we don't see a huge increase on a national scale, but what we are seeing is a 13% increase in meth-related offenses between 2017 and 2018. We are hearing a lot about police diversion, et cetera, and we know that it's taking place, but the fact that, over 47,000 police reported drug offenses, and this is excluding cannabis, in 2018 continue to take place. So that does still have a significant impact on policing and criminal justice costs in Canada. We're also seeing an increasing role in organized criminal groups, including transnational organized crime. When it comes to the illicit drug market, particularly when it comes to amphetamines, synthetics, precursor chemicals, et cetera, that are more easily transported and trafficked across borders. We're also seeing an increase in web-based criminal justice activities, so the supply of prohibited drugs through the dark web, for example. We also know from the criminal justice perspective that the majority of offenders that are in Canadian prisons have a history of problematic substance use. So again, we're seeing the conflation of health problems that are contributing to criminal justice impacts. Oops, sorry. There we go. One result of criminalization is a contaminated supply. What we're seeing increasingly, and this is a key driver in the fatality rates of the opioid crisis, are fentanyl and its analogs. Recent study published by CSM indicated that fentanyl and its analogs are common in the supply, with 62% of opioid-containing and 3% of stimulant-containing drugs between April 2018 and August 2019. So these are exclusively drugs that were sent by the police for analysis by Health Canada, containing fentanyl. When we go to drug checking services, so these are services in the community where, as a user of illicit drugs, you can go to the service, provide them with a small sample of the substance that you're going to use, and get that analyzed. 74% of those samples provided in Toronto contained fentanyl, and that was as high as 88% in BC. In BC, what we're hearing is approximately 14 to 36% of fentanyl exposure is unintentional. That's all the way up to 90% in Montreal. That's a significant concern, because if you don't know that your substance contains fentanyl, you are at much higher risk of overdose. What the BC numbers tell us, and what we're also hearing from the field, a lot of people tend to think that all fentanyl exposure is accidental, that people don't know they're using fentanyl. But with opioids, of course, your tolerance for different potency levels increases over time and with use. So as people have become more accustomed to substances that have fentanyl in them, it is actually intentional use of fentanyl. So people are seeking out the more concentrated substances. We're also seeing substances of even higher concentration, specifically with the synthetics. So we're seeing carfentanil, W18. There's a series of compounds referred to as the U series. I learned a new term yesterday. Apparently the utopioids they're being referred to as. So it's interesting, a Swiss colleague asked me a few years back, because a lot of the European countries haven't seen fentanyl to the same extent that Canada has. Why are dealers killing their customers? You know, why are they providing substances that they know are lethal? Isn't that bad for business to kill your clientele? So to explain that, I'm going to get into a little bit the iron law of prohibition. Basically what that means is, as soon as you prohibit a substance, you make it riskier to deal in. So there's an increased risk of criminal justice penalties at each step in the supply chain. Therefore, at each step in the supply chain, the cost increases exponentially. When you're dealing with trafficking, especially going across international borders, the smaller the package you can deal with, the easier it is to hide the substance. Therefore, you want to increase potency in order to reduce the bulk. That increases the danger of contamination for a couple of reasons. For one, the increased potency it's easy. It can be trafficked in a smaller package, and then when it reaches the destination, there are more bulking agents added to it. Those bulking agents can be extremely dangerous to consumer health. So in terms of connecting some of the dots, you know, why does international prohibition have the impact that it has? When you think about it, if the goal that we're working toward is a drug-free role, and the approach to get there is criminal prohibition, that means the illegal market costs are exponentially inflated. So like I said, due to the iron law of prohibition. Illegal drug production and trafficking is taking place in a global market. Coca is farmed in South America, opium is farmed in Afghanistan, precursor chemicals originate largely in China, and Mexico is the major supplier of cannabis to the US. When we think about that, and we think about the price increasing in each step in the way, that helps to, for one thing, that means there's an increased profit margin at each step in the process, which is what attracts organized crime. It's a fairly simple supply chain to deal in. There's a lot of disposable points along the way. Unfortunately, the person who is farming the crops in Colombia, for example, or the individual who is selling on the streets of Toronto, compared to the people who are at the top of the chain, are much less vulnerable to criminal prosecution and apprehension. And also fairly disposable. You can find more farmers, you can find more dealers. So the people who are operating at the international organized crime level are relatively protected. It's extremely expensive and extremely labor intensive, requires a lot of international coordination to successfully prosecute an illicit drug trafficking ring at the coordination level. When we think about criminal prohibition as our approach, we also feed into the idea that if drugs are bad, then people who use drugs are criminal. That means people who use drugs are bad because criminals are bad, right? So this is it's the overall framework that builds that stigma against people who use drugs. They're stigmatized by their use rather than being seen as individuals. So that makes it even harder to shift from the criminal justice and prohibition perspective into a health and social support perspective. And now we add the complexity of COVID-19. COVID-19 is increasing the risks associated with substance use, particularly among vulnerable populations. Vulnerable populations are facing increased risk of transmission when accessing or using drugs. So, we're all being told to shelter in place, to conduct physical distancing. When you're needing to leave whatever space you have in order to access drugs, possibly several times a day, that means you're exposing yourself to possible transmission. It also means that when you're, back up a bit, even for those who are accessing, for example, methadone, individuals are often required to do on-site clinic visits rather than being able to take home carries. So that might mean individuals have to go into the clinic multiple times a day or daily, which again increases potential risk of exposure simply by having to leave the house multiple times a day. Vulnerable populations in particular, so these are people who are street involved, who are marginally housed, who are perhaps living in shared accommodation or shelter settings, have reduced access to soap and water. We're telling people to wash your hands frequently. How do you do that if you don't have access to soap and water? Less access to showers, less access to laundry facilities, to cleaning supplies, just to maintain a safe space. And people who are street involved or living, for example, in some of the tent cities that we've seen in the media, don't have access to any of that. So it creates a huge vulnerability and a huge risk of transmission. What we're seeing in long-term care homes, in prisons, is that close confined quarters are at highest risk for greater disease transmission. We also know that many people, due to the physical impacts of substance use over the years, have compromised immune function. People who use drugs also have a higher prevalence of conditions such as COPD that can make them more vulnerable to the impacts of COVID. What we're seeing, what we're hearing a lot of concern about internationally. So as borders are being closed, the international nature of the drug trade is being interrupted. So supply chains are becoming more difficult because there's simply less traffic going in and out of countries that restrict the normal smuggling that would be happening. That means people are getting their drugs through different routes that might be of different compositions because each supply route has its own source, potency, etc., composition that they work with. As the supply chains change, that composition will change as well. That increases the risk of poisoning or overdose, which we're seeing. An example in Ottawa right now is we're seeing orange fentanyl in place of purple fentanyl, and we're seeing different overdose symptoms associated with that. So that presents a public health risk because there's less awareness and familiarity with how to best intervene in the overdose. We're hearing in the UK, for example, where there hasn't traditionally been a strong presence of fentanyl, we're hearing anecdotally that they're seeing more fentanyl on the streets. Again, suspected due to the interruption in supply routes and to the need to get more creative to reduce some of the risks associated with the traditional opium supply. So we're also hearing a lot of concern about price increases. Some of that is due to the changes in supply. So if it's becoming more difficult to traffic, that's going to mean that people are going to be charging more to do it. Even though we haven't necessarily seen consistent shortages across the board, and I say consistent because I know that there are some countries that have seen extreme shortages of some substances in particular. But in Canada so far, we haven't necessarily seen that to the same degree, but we are definitely seeing the price increases. Again, organized crime sees an opportunity to raise prices. They're going to take it, unfortunately. This at the same time that traditional economic means are more difficult for vulnerable populations. So if you think about people who have been paying to access substances through, for example, panhandling, there's less people on the streets, and virtually nobody is dealing in cash right now. So that makes panhandling very difficult. In terms of shoplifting, the stores are closed. There's nowhere to shoplift from. And much more visibility in the stores due to the physical distancing requirement and limited number of people who can be in the stores at any one time. The sex trade has been significantly shut down due to concerns with COVID, which is another economic source for supporting drug use. So just really very practical challenges, again, that are happening on an international scale. And one of the major risks associated with these challenges economically and in terms of supply chain is unplanned withdrawal. So that could be because people are unable to access their substance of choice. It could be because they don't have the economic means to pay for the substances, or it could mean that they are in isolation, unable to leave due either to symptoms or due to fear of contracting COVID. And if they have not supplied themselves with sufficient drugs to get them through that period of isolation, they could be looking at unsupported withdrawal, which can be a terrible experience as well as a health risk depending on what substances the person is withdrawing from, of course with significant risks associated with alcohol withdrawal. Oops. Sorry. We're also seeing reduced access to harm reduction and treatment services. Unfortunately, a lot of the harm reduction services have had significant challenges in accessing personal protection equipment. They've also had difficulty in ensuring that a lot of the staff are properly trained in its use. So a lot of harm reduction services engage peers in order to provide support, and they certainly do not want to put their peer workers at risk if they don't have access to the proper equipment and training to protect their health. Simply due to physical distancing requirements, a lot of harm reduction services are offered in fairly small spaces. There's generally a lot of congregation around those spaces, and with physical distancing in place, if the center is unable to make operational changes in order to accommodate that physical distancing, a lot of the shelters have had to shut down or reduce their hours or reduce the level of intake that they have. This decreases access to safer supplies, and when we know, that increases risk associated with all of the bloodborne virus transmission considerations, there's increased risk of transmission of COVID itself if we're talking about lack of access, for example, to mouthpieces or pipes for smoking drugs such as meth. And we're also seeing increased deaths due to overdose. So we had fortunately been seeing a decrease in overdose trends over the last several months, but we're seeing an uptick now in several cities. Many reasons. For one, the primary message in reducing death due to overdose is don't use alone, right? That's why Darren died. He didn't have anybody around to check on him. He didn't have anybody around to call 911. So if we're being told to physically isolate, that goes directly against all of the harm reduction messaging for opioid use. So that creates a huge risk there. Again, the potential of new supply chains and unpredictable levels of potency of the substances being used increases risk as well. And people may also be more hesitant to administer naloxone or to provide supportive breathing for fear of contracting COVID. Fortunately, there are things that we can do. A lot of municipalities have moved toward the provision of safe and supportive housing. I really want to emphasize the need for supportive housing here. So again, simply moving people from the streets into an empty hotel is not sufficient. We need to make sure that people have access to what they need to stay and to stay safe in those hotels, for example. And that can be moving harm reduction services on site. It can be provision of managed alcohol, for example, to make sure that people aren't either having to leave the safety of the facility or risk going into withdrawal for lack of access to alcohol or other substances. It can mean making sure that they have access to food, to basic healthcare, making sure that people have access to hygiene supplies. So there's been a lot of the hand washing stations that you would see at outdoor rock festivals, for example, are being put into urban centers where there are homeless and marginalized populations so that there's increased access to hygiene supplies. Because we know that a lot of the places that people would often go to, use a washroom or wash their hands, etc., shopping malls, are closed, and there is no longer access to those sources. We need to make sure that harm reduction and treatment services have PPE, that they are considered an essential service, and that all staff, including peers, are trained in the proper use of PPE and in physical distancing and how to keep themselves and their colleagues and clients safe. That's going to take targeted communication around risk reduction, really emphasizing the fact that physical distancing doesn't mean social isolation. And it means sharing information on where and when to access services. So if harm reduction hours are being cut down, making sure that that's communicated to people so that they don't show up to a closed door, making sure that they know when they can show up to an open door. Looking at strategies for maintaining connection, whether that's calling a friend when you're about to use, and like literally using over Zoom so that that person can call 911 if they need to, if there's an overdose situation. Health Canada has issued 2 sets of exemptions, one offering prescription management or lowering barriers to prescription management. So increasing access to carries, for example, increasing access to phone-based prescription renewals, and even allowing delivery of controlled substances in order to help facilitate people staying in place. There's also exemptions for amendments to supervised consumption and overdose prevention site operations that will allow sites to modify the physical space in order to allow physical distancing. BC has issued provincial guidelines to increase access to substitution treatments, and this is going beyond just methadone. This is substitution beyond the standard methadone buprenorphine, even including substitutes for people who are using stimulants. So this is something that falls under the kind of overall header of safer supply that has been in demand for many years. So we're seeing actually some really innovative and some would say long overdue responses being triggered by the current crisis. We are anticipating a very significant impact in terms of Canadians' mental health coming out of the COVID crisis. This has been seen internationally. There's been some initial studies out of Italy, for example, in terms of the mental health impacts of the healthcare workforce, as well as society as a whole, of the anxiety associated with contracting COVID, and also the social isolation. So we're anticipating that. We are seeing increases in alcohol consumption internationally. So there's been major studies rather in Canada, the UK, and Australia that have consistently shown approximately a 20% that approximately 20% of the population is reporting increased alcohol consumption following the start of COVID. So we can anticipate that's going to translate into more Canadians who need treatment and support services moving forward. And we know that we didn't necessarily have an optimal treatment system beforehand, so we need to look at how we can scale up to meet that demand and reduce the risks associated with substance use as we come out of the isolation period and move into the future. And of course, looking at alternatives to arrest. We know that prisons are a very high risk context for COVID transmission. How do we provide people with alternatives? How do we keep people out of the prison system? There are excellent diversion programs out there that I could spend another 50 minutes talking about, so I won't necessarily go too far down that road. But making sure that people are accessing, police can be an access to health services and not just to the criminal justice system. So using those alternatives that we do have even under the current context of prohibition. And finally, simply asking people what they need. So really peer engagement, people with lived experience, ask them what they need in order to stay safe during these stressful times. Going backwards. Recognizing that I am speaking to what I understand are a lot of healthcare professionals or people who are going to be healthcare professionals soon, I really need to communicate the importance of stigma and the impact that stigma has on people who are experiencing problems with substance use or who have been labeled as a problematic substance user. We know that stigma is the most frequently reported barrier to accessing services and supports in healthcare among people who use drugs. And we know that the healthcare profession has a significant role to play in reducing that stigma. We can do that simply by putting the person first. So rather than putting the drug use first when you see somebody presenting in front of you, think about the person. Some of you may have heard the name Dr. Gabor Mate. He's a service provider in Vancouver, and he's done a lot of publishing on trauma and on substance use. He recommends that we shift the question. The question under prohibition context is, why the drug use? We don't need to ask why the drugs, we need to ask why the pain. People take drugs for a reason. For many of us, it's recreational. On a sunny Saturday afternoon, some of you are possibly watching this webinar from your patio while drinking a beer. People use substances for various reasons. A lot of people who use substances do so to cope with pain. For Dan, it was physical pain associated with chronic injuries due to lifetime of labor. For Sue, it was probably emotional pain from the trauma that she may have experienced as a victim of sexual or physical abuse. So we need to start looking at why people are using substances. For those people who are the most vulnerable and the most marginalized, this applies in Canada and internationally, drugs can be the most reasonable coping strategy available to somebody in a completely unreasonable situation. If you're suffering violence, if you're suffering trauma, if you're on the streets, you're not in a safe space, substances can provide you just with that support that you need to make it through the day. And really, some people with lived and living experience have the most remarkable survival skills of any people that I have ever met in my life. And we need to look at that, and we need to look at the resilience of people as opposed to again, labeling them as being immoral, unfit, etc., or problematic. The label of the problematic patient is something that we hear way too often. When we hear the label of a problematic patient, we're blaming the individual rather than the approach. We need to start looking at why the approach to substance use that we've been taking hasn't been working. Okay, if just saying no doesn't work, maybe we need to look at alternatives. If our approach to treatment isn't working, we need to look at alternatives. We're doing that now, more so than we used to. Again, COVID through the BC guidelines is providing some really interesting opportunities to increase access to a safer supply. We need to be looking at that and whether it's effective, whether it could and should be scaled up and sustained into the future. A very important way, and I've heard this from many med students, that working with marginalized and vulnerable populations, whether that be through a placement or through a practicum, really opened their eyes and helped to reduce the stigma associated with that population. So again, coming back to Dan and Sue, making it about a person and really demystifying drug use can be so important in addressing stigma. And finally, I'll just close with learning about and applying effective approaches for patients who use substances. We know that, unfortunately, there's very, very little time for, in the medical training, for specifically addressing mental health, and even less time for addressing substance use. So whatever time we can give that and attention, I think is just critically important for better suiting the needs of our clients. When we look at the prevalence, again, not just talking about illegal drug use, but alcohol use as well, having the greatest impact on Canada on the population level. So again, I apologize for moving fairly quickly through the beginning part and hopefully slowed down to a bit of a comprehensible pace through the end, but I am very happy to go back to anything and address your questions or comments.
Yes, so hi. I will read the two questions that are in the chat. Oh, there are three now.
Okay.
So the first question is from Sophie Fournier. She's asking, do you have any numbers about the changes in the cost related to cannabis since it was legalized?
Not yet. Unfortunately, right now we only have the numbers up to 2017. So we, there's a time delay because a lot of our data comes from federal agencies like Statistics Canada, Canadian Institutes for Health Information. So there's a bit of a time lag in terms of access to data. So it'll be about another year or two. The other thing that's important to note about cannabis legalization is it's a process. It's not quite as simple as flipping a switch. However, and sorry for the rapid scrolling here, but if you look at the costs associated with cannabis, a major part of that is criminal justice related. And logic would dictate that with the removal of a lot of the criminal penalties associated with cannabis use, we're going to see a good chunk of that blue section at least go down. What we need to be mindful of, though, is whether we see the healthcare costs and productivity costs go up.
Okay, thank you. The next question is from Alexander Valerio. He's asking, would decriminalizing a lot of the opioids be too drastic of a step to destigmatize a lot of the substance use and allowing for safer provision and intake of the drugs?
That's $1 million question right now. And, certainly we're seeing a lot of demand for safer supply, and not just for the issue of stigmatization, but also to prevent, to intervene in the opioid crisis and prevent a lot of the deaths that we're seeing right now. When we talk about decriminalization, it's really interesting because there are a lot of options available right now under a decriminalization framework. So police officers do not have to arrest or prosecute. Even at the court level, you can be referred to a drug treatment court. You can be simply deferred to treatment and avoid prosecution. Section 56 of the Controlled Drugs and Substances Act allows for exemptions for health and scientific reasons. So there is already a lot of leeway, and we're seeing that operationalized in the BC guidelines that I mentioned earlier, and there's a link in the presentation, where clinicians can in fact prescribe access to a range of opioids, rather that would reduce the requirement for people to access at the street level. So I guess that was a roundabout answer to say that we see a lot of definitely a lot of promise in looking at the options. We need to be looking at options right now to better support people, again, just shifting from the criminal justice to the health perspective.
Yeah, okay, thank you. The next question is from Francisco Franco Pejo. He asked, was it easy to overcome any legal barriers in order to provide drugs that are not the usual legalized ones? You referred to stimulants.
Yeah, and again, the opportunity is there. It's about provinces and medical colleges putting the guidelines in place to support the prescription. So there's the Section 56 exemption that is available through Health Canada and the Controlled Drugs and Substances Act. So the opportunity is there. There is an opportunity at the both federal level and provincial level and the level of the colleges to push for broader application of that exemption. Yeah, so that's probably the easiest gateway in the short term. But there are certainly others, a more formal decriminalization process or even revisiting of the scheduling. But so it can be done. It does take time. It does take effort. But COVID has just demonstrated the fact that when push comes to shove, it can actually be done pretty quickly.
Okay, thank you. The next question is from Julien Bélanger. He's asking, will you have any clinical tips in order for people to actually open up about their drug consumption during a medical consultation?
What we've heard from people is the most important thing is a non-judgmental approach. And that means not using stigmatizing language, not being accusatory, simply having a reasonable discussion, approaching it the same way you would ask somebody, you know, about their diet, about how much exercise that they get. So it's really just a non-judgmental, open attitude. What we've heard from a lot of medical professionals is there's concern about breaching the subject because they're not comfortable with that next step in the discussion. Perhaps not familiar with what treatment services are available, perhaps not familiar with the evidence supporting treatment. So I'd also really like to, you know, communicate the message that there are services out there. You know, the system isn't perfect, but recovery is possible, improvement is possible, symptom management is possible. And again, it's just about getting the education. And if you as a clinician are not comfortable, there are ways to get education. You know, I'd refer you to ccsa.ca as a starting point. Certainly not the be all and end all when it comes to clinical guidelines, but we can help you get at the information that you need.
Okay, that was really insightful. Thank you. We have a few more questions. The next one is from Sami Kandek. He's asking, in the event of decriminalization, how can opioids be properly regulated to make sure the number of addicts decrease?
That's a big question. I think we have to look at what is our objective. If our objective is to reduce addiction, we need to look at why are people addicted in the first place? Going back to that question of why the pain? If the substance is addressing some sort of pain, how can we provide alternatives? And a lot of it is investment in health and social services. If it's chronic pain management, we know that that's something that our healthcare system does not do as well as it should. Providing better pain management strategies, providing better financial support for pain management strategies, recognizing that a lot of people are put on prescription medications because you know, things like massage therapy, chiropractic, et cetera, they don't have medical coverage for. So it's increasing access to services such as that. It's looking at the issue of income support and income equality. It's looking at better helping people to deal with trauma. It's providing psychosocial supports, counseling. You know, one thing that I think we're going to see really ramp up as a result of COVID is increased access to mental health supports, primarily virtual right now. But it'll be very interesting to see how much of that can be sustained, because really just access to that trauma-informed care to somebody who can really help fill whatever gap that substance use is filling is just so important. So again, decriminalization is not a panacea to the rate of people using substances. What it does is help to make sure that they have access, that rather than being put into the criminal justice system, that there are access to health and social measures instead.
Thank you very much. The next questions are from Mati Remen. She's asking, you just showed us a costs and harm chart where there's a huge chunk of lost productivity. How is this particular parameter calculated?
I would have to refer you to the technical report. You can go to www.csuch.ca, CSUCH.ca, for the full methodology, but a lot of it is premature death and years of lost economic contribution.
Okay, thank you. She's also asking, regarding cannabis, have we seen a large-scale impact on the illegal market? How are they dealing with this?
Again, a little bit too soon to say, and unfortunately very difficult to get at. What we're seeing is more Canadians are reporting that they're accessing their cannabis from the legal rather than the illegal market. So that's a positive, but we also know that in terms of implementation, we still don't have uniform coverage across Canada to a regulated supply. Certainly in the cities we do, but a lot of the rural areas, for example, don't necessarily have storefront access or have intermittent. So it's going to take time to shift completely away from the illegal supply. And it's unfortunately, again, too soon to say overall what the impact has been.
Okay, thank you. Next, what will be the role of a medical student in prevention of substance abuse in the society?
I think, again, just what I said earlier about including it as part of an assessment and making it part of the discussion as a healthcare provider, being aware of risks, being aware of flags, and being confident and comfortable in addressing those with your patients. You know, those working in an ER setting, we're doing some really interesting studies in acute alcohol poisoning, for example, particularly among college students in emergency rooms. And, you know, are there ways that we can set up rapid access through emergency visits, et cetera, and what is the most timely way to access patients? So a lot of it is, again, just becoming familiar with the topic of substance use, with effective approaches, and just being comfortable in broaching that subject with your patients, and having information available and resources available to help them through it. And I know that making those resources available is a challenge that we as a field have.
Thank you very much. Last question, I think, is from Fatine Karkri. She's asking, to what extent is post-operative pain management or use of fentanyl as a sedating agent in the ICU related to opioid dependence / crisis? What is the role of physicians in that particular setting?
I am not a clinician, so I want to be a little bit, I don't want to overstep my expertise in responding to that question. But I do know that we certainly, you know, I use the example of Dan, the construction worker, who got hooked after, you know, being taken off oxys for pain. And that's a story that we hear fairly frequently. So there certainly is a relationship there. And, you know, there's a pain task force actually that's been set up at the federal level to look at how we can improve our response to pain in Canada. And a part of that is looking at our use of opioids and how we can better support patients. It's not about stigmatizing the use of opioids in pain management. It's about learning how to more effectively support patients, and how can we increase access to other therapies that will reduce reliance on opioids, and for those that do require opioids, how can we make sure that they are using them in a way that is safe and safe but still effective. So I think it's just, we need to improve the way we respond to pain management in Canada.
Okay, thank you very much. I think that was it for the questions. Does anyone else have any question? You can either put them in the chat right now or activate your microphone and say them out loud.
I see there's a question about the website, so I'm just entering that into the chat.
Perfect, thank you.
Sorry, I just meant to send that to everybody.
Okay, perfect.
Yeah, and we're actually hoping to release the 2017 numbers in the next couple of weeks.
Oh, that's very great, thank you. So there's a new question from Nancy. She's asking, some countries like the Netherlands offer a very accessible screening test for drugs, pills purchased illegally. Do you think that these types of tests could potentially become available in Canada to prevent overdoses?
They actually are available. Yeah, primarily limited to urban centers, but Health Canada introduced new legislation about 1.5 years ago that increased access to drug checking facilities at the federal level. So we've actually seen one of the studies that I referred to, sorry for the flipping again, no, where was it? Nope, I've lost it. Anyway, oh, there we go. So some of this data, the 74% and 88% is from drug checking services in Toronto and BC. They also exist in Montreal. There's drug checking services at several of the major festivals. which won't be happening this year, but when they're back, post-COVID. So that is actually a service that is scaling up in Canada. And there was recently a report issued from a multi-site study that looked at some of the results from drug checking services, and we'll be issuing a report on that shortly. I'll just type into websites that will help to access that information if anybody's interested.
So we have a new question from Babette Benjamin Paul, and this will be our last question for today. She's asking, what should we do for pregnant women who practice cannabis?
Sorry, pregnant women who use cannabis?
Yeah, who use cannabis.
Advise against it. There is research, I know anecdotally some pregnant women use cannabis to address nausea, but there is research indicating that there are negative impacts on the fetus that exhibit in behavioral difficulties and cognitive issues, particularly seeing the behavioral difficulties more in the toddler age. But again, the research is pretty young, so we don't have a lot of longitudinal data that we would like to see yet, but we are seeing increased support for longer term impacts of cannabis use during pregnancy. So safest bet is to avoid it.
Okay, so thank you very much. Thank you very much, Ms. Jesseman, for sharing your expertise on such an important topic in our societies. It was a very insightful presentation. I think everyone believes this, and it was an honor to work with you. I wish you great success in your future endeavors.
Thank you very much. Have a lovely Friday afternoon.
Thank you. You too. So for everyone, this ends the 12th edition and the first online edition of the Global Health Colloquium of IFMSA Quebec. Thank you to our sponsors who are here and our speakers, Dr. Jean Zigby, Julian and Noemi from MQRP, Dr. Zeni Mojo, Ms. Rebecca Jesseman, Dr. Howard Bergman, and Ms. Laurence Monet. Also, thank you all for your participation. You all were the ones who truly made this a success. For those who were interested, you can make a demand for a participation certificate in the post-event survey that we will send to you in the next few days by email. And for those who registered to attend the General Assembly of IFMSA Quebec, the Zoom link have been sent to you by email by IFMSA Quebec. And if you cannot find it, we invite you to go see in your spams. Please note that it starts at 3:30 p.m. and will only be held in French. Lastly, all our conferences have been recorded today, and we will upload them in our YouTube channel, which will be shared to you by email. So you will have the possibility to watch other presentations that you were not able to attend to today, or watch the parts of the presentation that you saw today that you missed. So thank you all very much, and have a great day. We hope you learned a lot today, and see you next year at Université de Montréal for the 13th edition. Thank you.